from Hamad Medical College, and she will be the key resource speaker for today's webinar on burn care rehabilitation. I welcome Jayashree. Is she here? I cannot see her.
She was here all the moment, and she just kind of stepped away for a minute to kind of like do something with her presentation in a last minute tweak.
Okay.
She'll be here,
Okay.
sir.
Okay. Okay. And Bizani joined? Dr. Bizani joined?
I heard from Dr. Supli that Dr. Bijlani is having some schedule conflict, so she's not joining.
Okay. 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 So I also extend a warm welcome to Dr. Vijay Supli, convener of International Chapter of AIOTA, Dr. Jyotha, Secretary Council of Physiotherapy. They both constitute a good coordinated team, which has resulted into the series of webinars for AIOTA by International Chapter, even during this pandemic time. And support of Dr. Karthik Mani is also very much appreciated. So, Karthik, I also welcome you all. Welcome you.
Thank you, sir.
And I'm very happy to know that Karthik that he's prompt in responding to any letter or any query, whatever it is. I'm very happy for Karthik. At least I just resemble you with me, because I also take a note that all letters, all correspondence must be responded. I always tell my ECs, you must respond, whether it is positive or negative, whatever it is. So I'm very happy for Karthik that you are doing. I mean, your response is very quick and always very quick and prompt and up to the point.
Yes.
So today's webinar is on burn care rehabilitation. We all know that it is not a new chapter, but it is the least practiced area. I think not very much practiced. I mean, I don't think that there are many centers where OTs are working in the department of plastic surgery or a burn unit. I mean, there's still a lot need to go for this area to develop more. You know, the one of the main goals in rehabilitation of the patient with burns is their return to the society and return to their professional occupation, specifically those who are having burn in their hands. And that it will definitely improve, I mean, with the help of occupational therapy intervention, their quality of life. With early assessment and ongoing OT intervention, with an effective use of applied assistive technology, an individual recovering from a burn injury should be able to return to a functional life more rapidly. So I'm confident that this webinar today by Jayashree will address such issues, and the participant will be able to academically enrich their knowledge base and will apply those in their clinical practice. So this is all about the webinar, but I would like to, because we have got many participants and they all must be knowing what is going in India. So I'd like to share some recent significant achievement of AIOTA. Many of you know, many of you may not be knowing that the 28th March 2021 marked the beginning of a new era for occupational therapy professionals in India. The day marked the first step towards professional recognition, autonomy, and independence for all those who had been dreaming to get a national regulatory body for more than 4 decades. On this day, the National Commission for Allied and Health Care Profession Act 2021, with an independent Central Council of Occupational Therapy, came into existence. I feel pride to inform you that Act recognizes occupational therapy as an independent profession, as a recognized category of healthcare profession, which I'm sure is not available in many of the other countries. WFOT has also appreciated this move of India, and they congratulated India for this meticulous achievement, that in India now independent OT practice without the clutches, under the clutches of medical field has been enacted. So I congratulate you all for this achievement. I hope that now the profession will grow in a more effective and advanced way coming future in India. Just an information to you that Asia Oceanian Congress of Neuro Rehabilitation 2021, that is called as AOCNR 2021, is being organized by Indian Federation of Neuro Rehabilitation on virtual platform on 6th and 8th, from 6 to 8 August 2021. IOTA is also a supporting organization for this event. A 90-minute panel session on OT intervention in dementia is being arranged by IOTA on 8th of August from 12 to 1:30 p.m. Indian Standard Time with learned faculties from New Zealand, UK, and India. Those interested may register through IFNR website. My very best wishes to you all, and I hope that this webinar too will prove to be a great success as your past webinars in future. And I wish to see more such webinars during the pandemic time in collaboration with ICAIOTA and AIOTA. Thank you, Dr. Vijay Sopade. Thank you very much.
Thank you, sir.
Thank you so much, sir. I just kind of like requested the speaker to join back real quick so that I can introduce her. So in between, one other housekeeping thing that I forgot to add is that this meeting is being recorded, and also the recording will be available on our website, internationaliota.org, after a couple of weeks. So those who couldn't, get here today can still watch this webinar, recorded version of the webinar. So our plan is to continue this webinar, so continue to support us. We are doing this obviously at no cost, so please make sure that if you're committing yourself to show up, because there were a couple of, today the attendance is so good. I saw 125 plus and going. But you could still see it is only like 30 to 40% of the registered participants, and we really want to see. So make sure that if you're committing yourself, registering yourself, yes, put this on your calendar. And I always like send a reminder a couple of days prior. If you would register in the last minute, I cannot do that. But like as of Saturday morning Indian time, to all that 429 participants who registered by then, I sent the meeting reminder as well. So we would really appreciate, because a lot of effort and work are going into this. So please, make sure that if you're registering, plan to attend. Okay, or if you have any schedule conflict, please let us know, and also try to watch the recording of the webinar. Thank you. And Dr. Suple, would you like to really talk about any other initiative of the international chapter until Jayashree joins the call? I texted her already. I'll give her a call now.
Okay, sure. Thanks, Karthik. And I thank Dr. Srivastava, President of AIOTA, who could be here with us, and I really appreciate your presence, sir. And our chapter is striving really hard to provide this opportunity every other month. We have already like another webinar coming up in August, and then the last one would be October. And we are in the process of preparing calendar for 2020-22 actually. Yeah. And there are 6. I received 6 requests from the faculties and the specialists in their own field from overseas, like USA and other countries. So I'm kind of having a discussion with them. So this series of webinars will continue in future uninterrupted. And thanks for all the participants for their support. And like Karthik said, just if you registered, please make sure that you attend the webinar. And it takes a lot of efforts and planning to arrange everything, and especially for the speaker who does a lot of work like data collection and research work. So it's a good opportunity for people to learn, like OTs and OT students to learn. So I really appreciate everybody's participation today, and hopefully, like you will learn a lot of new techniques, new things from Jayashree's knowledge in this area. So looks like Jayashree is back here. So I'm going to hand over to Karthik. Are you there?
Yes, sir.
Okay, Jayashree there?
Yes, she's there as well.
Okay,
Yeah,
so
just a
yeah,
moment.
you
Again, still it's not the right slide. I will share the correct slide. Again, it is showing only 26. I'll just be with you. Give me a moment. I'll just stop sharing and I will share again.
Okay, just
yeah.
stay on the call and I'll go ahead and introduce you.
Yeah, I just introduce her. Okay, Karthik,
Okay.
and then
Sure,
I will go from there. She will continue.
sure thing.
Go
Right.
ahead.
So again, hello everyone. Today's speaker is, as you all know, Dr. Jayashree Chandramouli. She graduated with her baccalaureate degree in OT from SRM College of Occupational Therapy, and she obtained her master's MOT in 2007 with a specialization in hand conditions. Then she went on to pursue her CHT Certified Hand Therapy certification in 2014, and also she completed a PG certification in burn care in 2015. So all this shows us, she's an expert on this topic, and she is currently working as an burn specialist occupational therapist and a team leader in Al Wakra Hospital, Hamad Medical Corporation, Doha, Qatar, and she is on this role since 2007. So that's a long time. She has like some 14 years under her belt in the current position. She presented a paper in the AIOTA conference in 2006, and she also conducted a splinting workshop in July 2009 in Doha. We could even have her conduct a splinting workshop on behalf of the International Chapter sometime. And also she did some in-service stuff related to workplace safety. So it's my pleasure to welcome Dr. Jayashree Chandramouli to deliver this webinar on burn care. Again, just a quick note, make sure that you mute yourself unless you want to say something, and reserve your questions until the end. Jayashree, over to you.
Thank you, Karthik. I'm humbled. Anytime I'm associated with the International Chapter of Occupational Therapy, it's been almost 2 to 3 years. We are as a team, and we are very happy to be associated with IOTA. And as a graduate from Indian school, so we always carry something that when we are wanting to share our expertise, because I have never changed my field. It's from my time I graduated, I was always associated with hand therapy and burn care. Having said that, it gives immense pleasure to share whatever little I know in terms of burn care, along with the budding occupational therapist and the many tutors or many seniors. I'm seeing them in the participants list. It gives me immense pleasure, and thank you, International Chapter and AIOTA, for all the opportunities that I'm here today in front of you. I just declare that I don't have any conflict of interest. I'm not here promoting any product or anything. Having said that, on a slighter note, sorry for the apologies, because my slides were very big, huge size so I couldn't upload it as a one file. So you have to bear with me, as I have divided quickly into 3 sections, and then I'll be uploading one by one as I finish. And the burn pictures, I have put some patients' pictures, wound. So I'm just a note. If someone is not okay to see, maybe they can minimize the screen when the picture comes. But it's all with consent being taken from the patient. So without a further ado, on a lovely Sunday evening and then Sunday morning in those who are in different time zones, a very warm welcome to the burn care and rehabilitation from an occupational therapy perspective. I work in Hamad Medical Corporation, and I set up the hospital with the occupational therapy department. So it gives me a nice coverage for my journey, as I have started from where I began the burn care. And I owe my humble regards to all my seniors or tutors or lecturers and professors who have helped me to attain this milestone in my life. Okay, what is burns? It's when we talk about burns, we have to talk about the structure of the skin a little bit. The layer of the human skin also acts as a protective covering, and it regulates the temperature of the human body. It is divided into 3 layers: epidermis, dermis, and hypodermis. So what happens in the case of burns per se? The injury affects to skin and the underlying tissue. So as we say, human skin, it can tolerate about 42 degrees Celsius to 440 degrees Celsius. So anything which goes above and beyond this temperature, the skin won't survive. So in nutshell, as the temperature and the time of exposure increases, the destruction of the tissue will be severe. The classification of burns. When we talk about burns, it's better that we know about the source which has caused the burns. So the first classification of burns will be by the source of injury, how it occurred. It could be into scald, which is like hot fluids, flame burns, it could be direct fire, electrical burns, where it leaves an entry and exit route of electrical current. So you have to look for the two spots where there is an entry, where there is an exit. And in chemical burns, which is accounting to 0.2%, which is like less commonly seen, which is mostly it could be acidic in nature or alkali in nature. When it reacts with skin, it eat away the skin in different layers. The fifth one is a radiational burn, which is very peculiar in common when you're undergoing radiation therapy in terms of cancer or other conditions. It can lead to the erosion of the underlying skin, which could be superficial or it could go more deep, which will be the next classification which we are seeing. Depending on the extent of the depth, it could be superficial or it could be superficial deep, or it could be superficial partial thickness or deep partial thickness, and then comes the full thickness. These are the three different classifications depending upon the extent. When we talk about the superficial burns, where it involves only the superficial epidermis, which is the first and the foremost layer where you have the hair follicles in few areas. If you sustain, or if the burns is supposed to be a superficial burns, you will often see lot of erythema, which is like redness, pain, and slight swelling. Usually there are no blisters if the burns are superficial, because the tissue damage is very minimal, and eventually the pain resolves in 2 to 3 days. But whereas if you see that the source of injury was like contacting your surface for a longer time, then it's more likely that it could have caused damage to the more underlying tissues, which is like involving epidermis and a part or a full of dermis. So in case of superficial partial thickness or a deep partial thickness, it's very important to mention that these are extremely painful part of the injury, because it leaves the intact nerve ending. So the nerve endings are intact in this case. That means you will perceive a horrible pain. It usually heals in 7 to 14 days if there was no signs of infection. And in this type of burns, if you see the picture, vesicles and blisters are the characteristic feature. So if you see a blisters or if you see a vesicles or ruptured, then you could easily arrive at a conclusion that it's a superficial or a deep partial thickness burn. Moving ahead is the full thickness burns, where it involves a complete of epidermis, dermis, and hypodermis. And having said that, it is the severe most burns, but it won't be painful because all the nerve endings are damaged, and there would be excessive fluid and metabolic deficit that one has to undergo if he would have confronted full thickness burn. The survivor may need a skin thick coverage, like it could be like split thickness or a full thickness graft, depending upon the extent of damage, because these wounds won't heal by itself because if it's a larger surface area. But if it's a smaller surface area, it could heal by wound contraction, and it would leave a very unpleasant scar. So these are the characteristics as by the you could expect as per the outcome of the burns that we are confronting. Now, the third classification is by that we are categorizing the burns by body surface area, like how much the part of the body is burned. Thanks to Lundbroder's chart, which talks about how much percentage, if the burns is in the trunk or if the burns is in the face, if it's in the peripheries, if it's in the lower extremity, if it's in the genitalia. It depends upon different age group, whereas in pediatrics, the head and the face carries an importance of 18%, whereas in adult it's 9%. So the charts are self-explanatory over there, and it's available everywhere for everyone to browse through if they have any doubt. This is little bit misleading because a person who is having like a 70% of body surface area, maybe all the 70% could be superficial. So having said that, this doesn't give any clear idea about the depth of the injury. Okay, it just talks about area of involvement. It does not mention anything about the extent of the burns. So it's very important that the body surface area is calculated upon admission, because upon this as a baseline, the fluid resuscitation will be calculated upon depending upon their body weight. So that's why mentioning the total body surface area is very important in a burn care victim. We have talked about the classification of burns and the extent of the burns, but it would be noteworthy for each one to talk about what will be the first and foremost first aid measures, if at all, if one is confronting. God forbid one should have, but if at all, okay, okay, the first aid measures, if at all, burn victim confronts an unfortunate event, would be extinguish the burn by appropriate methods. And having said that, we have to use a proper extinguisher, because having said that, water is not appropriate in all given circumstances. So you have to know the source of the injury and the scene of the incident before you opt for the extinguishing. And once you confront the victim, it could be we should mainly focusing on clearing the airway and removing any concentric clothing or accessories, which can lead to compartment syndrome, or it could obstruct the airway or the breathing. That would be our first priority. And then moving on, we want to wash or irrigate with water if it is appropriate, depending upon the source of the injury, because there are certain source of burns in which water could not be used as a irrigating agent. So it's better to know the appropriate source which caused the injury and then opt for the irrigating agent. And it's important to cover the wound with clean and dry appropriate agent, because many instances people put ice. So applying ice is not at all advisable, even if we happen to have like any day-to-day injury when you're cooking or when you're doing something. Please do not put ice, because applying ice directly on the burns would lead to rapid cooling that causes hypothermia, and it would hamper the circulation or the perfusion of the capillaries. So direct application of cold ice is a big no. And if at all the burns occurs due to a hot tar, then the appropriate irrigating agent is mineral oil. So when sometimes laying road during road laying, if anyone confronts the tar burn victim, so just a special note that mineral oil can be used as a agent of cleaning it. It looks simple, but then until unless if we confront it in our daily life, it's not simple. So having said that, does all the burn need hospitalization? No. Then we would be having shortfall of hospitals for such trivial injuries. There is a set criteria which kind of burns required hospitalization. As per the Lundbroder's chart, if the body surface area is more than 10%, and if it is in mentioning that particularly, there is a special exception if there is more than 2% full thickness burns that needs hospitalization. In a different age group, like if the victim is less than 2 years or if the victim is above 40 years. So acute, like pediatric and the above the middle age also needs hospitalization. Having said that, if the patient has any specific comorbidities, if there is any, if the patient is an immunocompromised patient, or if the patient has any chronic illness, then those patients should be considered for hospitalization. As per the area of involvement, if it involves hands, face, feet, and genitalia, then it's definitely a yes, yes, yes for hospitalization. If you suspect, if the patient was covered in the midst of a smoke, or if there would be a cause of inhalational injury, then definitely the patient requires hospitalization, because you cannot receive anything from the victim. Many a times the victim is unconscious, so it's better to observe the patient for an inhalational injury and then see how he recovers. In terms of circumferential burns, if the burns are already infected, then the patient definitely requires hospitalization. As I mentioned, history of chronic medical illness or any associated injuries. Let me explain a bit about. As burns occurs as a case of an accident, many a times the victim has to jump out for, you have to run for your life. So either the patient will jump through like a first floor building or some apartment or some scene where he is trying to escape the scene. So there is likely that he would have sustained any fractures. So we have to look for any associated injuries. Sometimes the patient would be in coma and they would be unable to cope the situation when they are unconscious. Having said that, it's a little bit important to know about the medical management if at all we are going to treat a burn patient. Having said that, cardiopulmonary stabilization or resuscitation comes first in any burn care victim, and followed by the fluid resuscitation and the lab works to know the extent of the burns and how much you are going to resuscitate with how much amount of fluid for the patient when the patient is hospitalized. Then followed by wound care and infection prevention and control measures. And having said that, keeping in mind the current situation, especially it's very important to do the swabbing to know that the patient is corona positive or not, because then the management is going to be in a different setup. He would be in a COVID positive hospital. If he happened to be COVID negative, then he would be in a different facility. So at this pandemic, it's very important. So we follow those infection prevention and control measures. Having said that, the next part of focus would be on pain relief and psychological support, because as I said, usually it's a traumatic event, so they are many a times anxious. Maybe they would have lost some of their near and dear ones in the scene. So if they happen to have intact nerve endings like in the superficial or the partial thickness burns, so they are going to be experiencing awful lot of pain, so which says that we have to focus a little bit on a pain relief and psychological support. And next in the line would be our nutritional support, and then comes our therapy part, occupational and physical therapy. In terms of inhalational injury, when there is a smoke, it's a serious threat. The early symptoms could be like carbon monoxide poisoning, airway obstruction, and pulmonary edema. If you fail to do that, later on complication, the patient will be a victim of acute respiratory distress syndrome in 24 to 48 hours, or he may land up with a pneumonia or pulmonary emboli as a late complications. So having said that, how you are going to make out if the patient has had a inhalational injury? You can look for the facial burns, and the hair would be singed, and there would be carbonaceous particles in his nostrils. Often there would be like a facial edema, and such patients definitely need an observation in the critical care unit, and we have to wait for those lab investigations for carboxy hemoglobin level and arterial and blood gas analysis. So in such cases, they would be in the surgical ICU or like a critical care unit, where they would be on airway maintenance, intubation or ventilator support, and intensive chest physiotherapy or pulmonary drainage or other procedures by a respiratory therapist. So having said all that, in acute stage, what happens to a burns victim? There is an increased permeability of the tissue per se in the burn victim, which leads to resultant hypoproteinemia. Like as the protein leakage occurs, it leads to loss of water and electrolytes, and it can cause edema, and it can constrict the vascular compartment. For example, if our extremities like forearm or leg, this acts as a compartment, because if the edema is keep on increasing, then there would be a chance of compartment syndrome. And there are chances that the patient will go to severe hemoconcentration. That is, there would be increased osmotic pressure in the interstitial cell space, and which cause a potential inward shift of sodium and water. So having said all that, as an occupational therapist, we are not going to do anything in this, but it's important to know that what patient is undergoing, because you should know everything about the patient when he's under your care. So the fluid resuscitation, usually they use a Parkland formula, which is like 4 ml of ringer lactate solution per kg body weight per percentage of body surface area burned. And usually they do a follow-up dose during the second day, which would be half the quantity of the previous mentioned formula. It is very, very important because the fluid resuscitation helps in preserving the zone of stasis. If you see this figure of like a concentric circle, you might be thinking that are we going to do a dart game? No, we are not going to throw darts. These are 3 zones, which is the reddish one is a zone of inflammation, and the extreme inner concentric circle is a zone of necrosis. That means the black one is the part where directly the skin has sustained the source. So that means already the skin has necrotized. The middle portion of yellow color or the orangish yellow, this is very important for us, because if a patient is properly resuscitated, or he's properly taken care of in a hospital, the pathophysiological response depends on the fluid resuscitation. So that preservation of an orange zone is still under the hands of the treating burn surgeon. If he would be properly resuscitated, if enough fluids have been given on time, so it would expand into zone of inflammation, whereas we can limit the zone of necrosis. We can limit the dead cells to a particular zone. But if we fail to do so, then this zone of necrosis will expand, and it will eat away all the zone of stasis. So that means the damage will progress if the patient is not being resuscitated well. In a burn care victim, giving appropriate nutritional support is very, very important to enhance the process of recovery. Having said that, it's a team approach, so obviously the dietitian is involved in the burn care victims line of management. It depends upon, as per the Schreiner's Burn Institute at Texas, they have a different calorie intake for the age group, like infants, adolescents, and children and adults. Usually for infants, it's somewhere between 1,000 kilocalories, and for 2 to 15 years of age, it's 1,300, and adolescents, it's 1,500 kilocalories per square meter of body surface area burned. And for adults, it's usually 2,000 calories, high protein diet. Having said that, we have to take care of comorbidities. The patient can be a chronic diabetic, or he would be hypertensive. This all has to be borne in mind. And especially when the patient cannot eat, or only he is relying on the IV fluids, it's wise that they would be start on an NG tube or enteral feeding, or as an oral supplement. They would be on enteral feed. It's a nice graph if we discuss about the wound care and the infection control practices. It gives a wide array of, the paradigm shift. It as we progress in the x-axis and y-axis apart, say from 1940 to 2020, we are in 80 years of the span of burn care. It started with penicillin. So initially in 1942, penicillin was administered for burn care patients, but as the time progressed, we came up with a formula of Lundebrauder chart. And one moment, I think my screen was.
Your screen kind of disappeared. So if you want to share it again and kind of move to that
Yeah,
slide
sure,
that
I'll do
you're
that.
talking about. Yeah,
Excuse, yeah, give me a moment.
sure. And I'm glad you talked about Shriners Hospital, which is just a block away from my building in Galveston.
Excellent, excellent. See, the world is small, Karthik. Wherever we are going, we are here in touch, either through virtual, thanks to Corona. No, these are a few positive aspects of looking at the pandemic, you see.
Sure thing. Yeah. I don't know, Dr. Suresh Kumar Kamalakaran is here. He, in fact, wrote an article about, I think, some positive aspects for the people with disabilities due to Corona, as well as the impacts. So are you able to share it again?
I'm trying.
Okay.
As I said, because my presentation was a bit longer, so I have to divide in portions. So that's the main reason. Maybe the one presentation would have got completed, then I should upload the second one.
Probably.
Okay, I'm sorry for that, because a lot of information cannot fit in one slide, so I have to. I think it. Where were we? Okay.
You're unable to move?
I think my system seems to be very slow. Yeah, we were here. We were talking about the nutritional support. Yep, and then after that, I think, okay, we were talking about the wound care, like when those days they were doing a penicillin administration for a patient. And in 1944 came the Lundebrauder chart. And then as we move forward, there were so many, boons came across as we progressed in the wound care graph. It was like we got the Parkland's formula, and then came the evolution of use of silver nitrite, or like silver sulfadizine or flamazine. It has many commercial names. And the current trend is, as we move more towards, like we are using like allograft, integra, or bovine graft, or matriderm. And there came another breakthrough of using allograft through skin banks and skin transplants, like how you donate like your organs, you can be like a skin donor as well. And instead of when the patient has an extensive involvement of burn, say like 55%, where almost all of the body surface area was burned, the patient cannot have any donor area from where you take from the other part, because everywhere it's burned. So there comes this use of allograft or a biodegradable skin substitutes, or they even you take the keratinocytes and they do processed cultural epitheliolites. So this could be used. They process them in a medium and they grow it and they put it on the patient. So there is amazing advancements in the field of burn care, which can lead to less trauma. Having said that, it's mainly the lecture is meant for all India occupational therapy. So it's high time we talk about a little bit of burn care in India. So these are the statistics which was from 2020. I'm glad to share with you. It's from the National Program for Prevention of Burn Injuries. There were around 7 million burns which occurs in India every year. Having said that, it's amazing that they say that more than 90% were preventable, but it was not prevented. Most common age group affected is between 20 to 40 years of age. I just want to make a note in this age group, because usually this is the age group where they are like mostly involved in work. They are the breadwinners of the family. So 20 to 40 years of age is the susceptible group of burns. So having said that, they talk about these 7 million burns victims where they undergo the burn care. 44.8% of the burn survivors, they were being taken care by government institutions, and I would say like a little bit higher chunk, 55.2% were being treated in a private institutions. You see, the difference of care is depending upon the availability. Having talked about it, there was a journal which was published in, there was an article which was published in Journal of Burn Care and Research in 2020, which talks about the geospatial mapping as a guide for resource allocation among the burn centers in India. Just a gist of it from this journal, it's like they say that 67 major burn centers are there in India, and of which we have around 1,339 inpatient beds. Having said all that, it is serving, as per our population status, it's zero point 0.1 per 100,000 of the population of Indian. Um, it's hopefully it will eventually improve, but it's just the statistics which was mentioned. 297 burn specific intensive care unit beds, and there are 79% of ICU beds with dialysis facilities. Okay, we talked a little bit of this current trend of skin banking. So presently in India, we have around 9 skin banks. Having said that, might be wondering there are only 7 places, but a couple of them have 2 centers, which is like in Mumbai and Chennai, there are 2 centers, so which all together accumulates to the count of 9. And it was very interesting as I was Googling through yesterday when I was preparing for this. It shows currently we have 16 skin banks. So this was the statistics from 2020. I got it. So recent more update from day before yesterday, I browsed it. It was like showing 16 skin banks in India. I think there was one in Nashik, Sangli, and I'm not sure. More and more places are adding in, because as the concept of skin donation is becoming popular among people, so there are more skin banks, opening up in India. The same journal, which gives a little bit of insight about how are we positioned in terms of the care of burn for burns victim. There were 75.1% of percentage of people who are like having access to the burn services. I think again my share screen has been taken away. One moment, I'll try to share it again.
Yes, while you're sharing, oh, I just saw a hand. Okay, I think it was by mistake. Okay.
See, just it gives a different statistics of how many persons are having, like how many percentage of population is located very close to a burn care center. So that gives a rough idea that how are we, placed in terms of the burn care for the burn victim. Just a moment. Even though the technology has to be applauded, sometimes there are slight glitches. So I apologize for that. Bear with me. When the IT has a pro, it also has a con. So I think these are the slighter glitches for that. I'm not quite sure why I'm unable to share my screen. Sorry for that.
So,
I just heard like a update from one of those doctors who were treating in Keel Park Medical College, which was in Chennai, because that the plastic surgeon happened to be here in Qatar last year on a locum. So he was telling like used to be like somewhere in hundreds, like say 200 to 300. So they say that they are treating that many number of victims per day. So it would be either through OPDs altogether. I'm talking about both the inpatient and the outpatient statistics here. Yeah. Okay. So 64.4% of population are placed well within that they are within 2 hours of a burn specific ICU, like intensive care unit. And 21.8% of population are within 2 hours of access from a place where with a skin bank. And the topmost, the creamy layer or the top of the pyramid is that 15.9% of the burn care victim are having accessibility within 2 hours to a place where they have both ICU and then skin bank together. Um, when we are talking about the scene of the burn, it's usually like something out of the blue happens. So it's like quite devastating if a burn survivor has to undergo, you know, series of unfortunate events. Like, so it's like maybe he'll be suddenly sleeping and then his building catches like a short circuit or something. So taking a good, psychological support and providing them proper analgesics and anxiolytics, narcotics, it's very important prior to the change of dressing, because they are undergoing pain and agony, which is like you can't see this side of it. And having said that, they would have gone for an emotional, devastating circumstances. So many a times they could be a victim of PTSD, which is like post-traumatic stress disorder. Maybe they would have lost any one of their colleague or anything. So, keeping in mind the psychological aspect, it's very important. Having said that, the family has to be supportive, because the awaiting rehabilitation process is not easy with the cosmetic acceptance. The family has to support them in the long term. Having said all this, the approach to burn care, it should be like every person who touches a burn survivor can positively impact the patient's outcome. This was a lecture from Burn Association in 2004. They say that when hospitalized, 84% of major burn patients suffer severe and excruciating pain, and 100% of the victims suffer daily pain, and 92% are awoken at night, in the middle of the night, with pain. So with this in mind, that the burn care team must be considering the focus of the quality of outcome must be worth of the pain survival, because the so much that the patient is undergoing. It's a quick, cyclical representation of how a burn patient journey is going to be. Like once the burn injury occurs at the scene, he undergoes a first aid, and there is appropriate communication, or sometimes air resuscitation or whatever, that he's been removed from the scene, and then he would be transported in the proper way to the nearest hospital for the hospitalization. And the treatment undergone by the patient. And this is where, as a multidisciplinary team, that we stand, very important in the phase of the burn care. Next is the discharge. So when we are discharging the patient, the discharge process would be like, either you should make sure that the patient goes back into his work or school, whatever, depending upon the age. And you have to prepare the family for the support, and you have to integrate them with the community. So this process, I have divided in this vicious cycle into 3 phases, in which I'll be focusing on my lecture about acute phase and rehabilitative or reconstructive phase and the reintegrative phase. Acute phase, where the positioning and edema management comes, and there is a rehabilitation and reconstruction phase where the therapy is geared towards obtaining maximum range of motion and functional independence. And in the reintegration phase, we are looking forward for a satisfactory cosmetic result. In the acute phase, our important role as a OT is the therapeutic positioning, edema management, which we do by means of providing orthotics and splints, and we do give exercises for the patient. As I talked about edema, edema is the body response to trauma, and there is an increase in the capillary permeability. That's why there is extra fluid happens in the intercellular space. And early deformities are primarily the result of edema. This is why early positioning is very, very important in this case. Edema control is a team approach. We need to rely upon the assigned nurses or the family so that the position is maintained when we are away. We are maybe working in a hospital for 8 hours or something. So the continuity of care has to happen properly through proper endorsement. Elevation of extremities above the heart level. And if we don't take care of this edema, it's going to be a silent culprit, which will lead to contractures and deformities at a later phase. Therapeutic positioning is very important as a OT, which can help in minimize the edema formation, enhance the fluid drainage, and you try to position the tendons and ligaments and joint capsule in its elongated position, and we can maintain the soft tissues, and that's how we can prevent the contractures. It's a quick glance of top to toe positioning, and here maybe I have some pictures which will be having wound, so just a word of caution for everyone. In case if the patient is having an anterior neck burn, so there is a high chance that the patient would go for a flexion contracture. So you should optimally position the patient in extension. If the patient is having a shoulder or a neck burn, the pillow should be kept, under the scapula, so where the patient can easily achieve the neck extension. If the patient happens to have like a shoulder burn, like involving the axilla, where the patient has to be kept in the maximum shoulder abduction, which is like 90 degrees, so that he won't develop any further axillary contracture. Having said that, this is my part 1, so I'll go for the second part of the lecture. I'll just, bear with me for the, I will share the second presentation. So when we are talking about the axillary contracture, where the patient may land up in post-bone contracture, where he has to undergo revision surgeries at the later time. So if the patient is having an axillary burn, the patient has to be positioned in shoulder abduction of 90 degree, where it's very important that you maintain that soft tissues in an elongated position. So later on, the patient doesn't have to, have any poor outcomes at a later stage. I'm trying to open. Having talked about a shoulder, now we will proceed to our next joint in the upper extremity, which is like the elbow. So the elbow has to be always positioned in extension. I'm not going to rely on my slide. My slide is taking some time to open. So always there is a tendency for the elbow to go into a flexion, or this is like fetal position, always the position of comfort for the burn victim. So always make a point that you maintain the elbow in extension in terms of the elbow burns or the anterior aspect, where you maintain the cubital fossa in full extension. In terms of wrist and hands, there is a tendency for the patient that they develop like a claw position. So always keep in mind that wrist extension is always the functional position. So we should position the patient in wrist extension and MP joint flexion. So I have one of the functional position splint, which will show, you know, in what way that we should position the hand. In case if the patient is having like a dorsal hand burn, it's wise to mention the patient with functional position, which is like, you know, you would have learned in your school about the functional position, the lumbrical position. So this is one thing. If the patient happens to have a dorsal hand burn, many a times when there is a burn injury happening, it's a natural human instinct to protect your face. So when you cover your face, that's how you confront the dorsal hand burn many a times. When you see a patient having a volar hand burns, this would be like a source of hot. When you try to touch something and then that object would have bursted, or you would have come in contact with a volar surface, that is a palmar surface of the finger. So in that cases, the positioning is slightly different, where you want to, you know, maintain the web in a full extension web space. Okay, as I said, elbow extension. Yeah, this is a volar hand burns. Usually children are more susceptible because they are crawling, they go and touch something. So it's very common type of injury in pediatric population. Yeah, as I said, functional position, I showed the splint. When we talk about the lower extremity, we don't want the frog position, like the external rotated leg with abduction. We want to keep the hip inflection, knee in extension, and neutral in terms of rotation. So we can use wedges with strap for that. As I said, knee is like same mirror image of the elbow. So we want the knee to be in extended, because we don't want a victim to land up with knee flexion contracture, which will be hindering him to walk at a later time when he recovers. And when the patients are prolonged bedridden, they would be landing up with foot drop. So you don't want ankle plantar flexion. So you want to position the patient's foot in dorsiflexion. It can be with whatever the resources available. It could be pillows or splints, whatever. This tabular column gives a gist of the positioning from top to toe. I spoke about neck, axilla, elbow, hands, wrist, the hips, and the knees. Okay, having said this, how the outcome is going to be, outweighed. What is a good outcome? Shifting perspective, reducing mortality rate is not only a good outcome. Having a quality of life, emphasis on a good functional and aesthetic outcome. Shorter delays in proper positioning can cause permanent damage. So if you have a burn hand, if you position in the acute phase properly, so you can prevent it from occurring a functional loss. When we are prescribing exercises to the burns patient, it should be kept in mind depending upon the phase of the wound healing, extent of the tendon and the joint involvement, and the patient's compliance. Usually, we have to keep in mind the depth and the location of the burns, and it's best that we coordinate our exercise regime in time after the administration of analgesic, because the patient is undergoing awful lot of pain. There are few precautions and contraindications if the patient has a cellulitis or a heterotrophic ossification, especially in terms of elbow or knee joint. If the patient has any exposed joints, tendons, then they should be immobilized. If the patient has undergone any graft or any skin coverage, then the patient should be immobilized for few days, depending upon the the type of graft that he has undergone. See, this is one of the wound where there is the extensor tendons are exposed. So in this case, if you are forcing him to move, you will lead to tendon rupture, where the patient will eventually land up with a Boutonniere deformity. So in such cases, you have to advise the patient not to make a composite fist at once. So having said that, are we not going to move them? No, we are going to move them in parts. That we will ask the patient to do like a hook fist, and like an intrinsic plus position, and then the intrinsic minus. We advise the patient not to make a composite fist. So this concludes our, our exercises. Now we are moving ahead with the rehabilitative part, where the main focus is the patient is medically stable, he's out. So we are focusing on his activities of daily living and splinting and more of conditioning or strengthening exercises. It's very important you involve the patient to do his activities of daily living. That's where, as a OT, it's a very primary, important area and very pivotal that we don't lose this. Otherwise, we will lose our identity. So we use adaptive devices. How often you involve them in their self-care, they feel a sense of motivation and gratification. They feel like a sense of meaningfulness in their life. And having said that, when we are in the rehabilitative force, what types of splints should be considered? The wounds have healed, but there is a still contractile forces which is happening around, which may remain active for 18 to 24 months. So the splints that we fabricate at this level should help to reduce the contractures non-surgically and maintain the normal body contours, and it should complement the pressure therapy. This is one of the splint where we are working on a prevention of the PIP flexion contracture. Upon fabrication of this splint, the patient can prevent landing up in PIP flexion contracture. So when you put the splint, gradually you can extend the PIP of the fingers. So that's what the splint meant for. So in the wound healing phase, the splints aid should be preventing the development of contractures. They can be used as an immobilizer if the patient has undergone skin graft, and it should be conforming the body if you are using it as an immobilizer. This is a one picture where the patient was taken care of, healed, grafted, everything, but whatever the graft he has undergone on the dorsum part of the wrist, it has shrunk, and then it led to an extension contracture. It's very unusual to see extension contracture. Usually you will see flexion contracture. So this child was unable to make a fist or grasp things or play or catch a toy in his day-to-day lives, where he has to undergo like a couple of revision surgeries and augment it with the splint. When we talk about splint, what are all the basic requirements of splint? The splint should be properly fitting, otherwise it would be like causing nerve compression, or it would lead pressure sores over a bony areas. It should be easy to clean, and as I said, pressure areas should be avoided. Periodic removal of a splint and regular view is important. And see, because if you're splinting a pediatric population, you should get to see them time to time, as the child will outgrow the splint eventually. The function and the purpose of the splint should be clearly communicated to the family members and medical staff and the patient himself for a better compliance. At the rehabilitative phase, our main concern will be you prevent the deformity and contracture by means of splinting, pressure garment, and therapeutic exercises. You try to bring the patient back to the normal activities of daily living. When we talk about some of our innovative things that we could use for the patient, if the patient has an anterior neck burn, you could just use a cuff and collar sling and just insert it into the tubinet and put it on the neck of the patient. You don't have to, use a fancy gadget in fabricating like a cervical collar or orthosis. So this time to time, you can increase it as the neck extension increase. Just a simple thing, it would go way handy in terms of burns patients' progress. See this patient who is in the middle picture having an axillary contracture, because after grafting, his graft started shrinking. And in the middle of the pandemic, he was not being followed up, or he missed a couple of, follow-ups. So in such cases, we do fabricate an aeroplane splint where we, work on the shoulder extension, shoulder abduction overhead. So gradually, when we gain those movement, we have to remold the splint eventually. This is one condition where the patient burn care victim land up with microstomia, which is like difficulty in mouth opening. This mainly occurs in the patient who has a facial injuries or who were on ventilator support for a long time. So in such cases, the patient was not moving, he was unconscious, or either he was on an NG tube. So they will land up with contractures at the corners of the mouth, which would prevent them from smiling, or which would prevent them to open up for eating or whatever the day-to-day activities. So this was one of a splint which we fabricated, a microstomia splint, which helps in jaw and horizontal mouth opening for a burn patient. Having said that, the splints can be of different varieties depending upon what need are you going to cater for your patient population. The splints could be like a static splint, or it could be a dynamic splint, or it could be a static progressive splint. Dynamic splints where you use elastic tractions. So the elastic will do the job and you just relax it. It will bring the patient's fingers back in position. So these are all a few things that which comes as a jiffy, because we want the patient to move their hands as early as possible. We don't want to prolong the patient to be in immobilized position and later land up with contractures and deformity. And having said about dynamic splints, it's very important to talk about the next variety, which is like a static progressive splint, where you position the patient's joint in a particular position and you pull the joints with a fish line and through a outrigger. So as the patient's range of motion increases, then you remold the splint or readjust the traction. Having said that, the static progressive splints should give a low load for a prolonged period of time. See, by means of putting a splint on a patient, in no way you should cause harm or acute inflammatory signs. So it should be like as tolerated by the patient. Now we talk about the functional mobility. So once the patient is stable, he walks out, we can bring the patient to the therapy room or the activity room, where we involve him for a few strengthening exercises. So where he actively does, as a OT, we all know that all the standing board or the shoulder arc or the shoulder wheel exercises that each one would have gone through in our early years of practice or when we are students. So for OT, activity is a main backbone. So we involve the patients through activity. It could be either purposeful for them, meaningful for them, and then that's how we, involve or engage the patient in their rehabilitation process. That concludes my second presentation. I'm going to share the third part of my presentation. Just bear with me. The slides are uploading. When we talk about, as I said, that the burn victim is mainly between the age group of 20 to 40 years. So, when at this age group, you have to prepare them, kind of reconditioning them to go back to their work, focus on the strengthening exercises and ask them what is their previous job. So we try to fit in, as close as possible. I think this is not the slide. If the patient happens to be like he's a adolescent, so you have to try to incorporate school going activities like writing, or you have to focus on his handwriting, or those kind of things has to be kept in mind, depending upon the age group that you are dealing. Because as an adolescent, their body is undergoing, a whole lot of changes. So they'll be having a lot of difficulty in coping up with their cosmetic appearance. So all this have to be borne in mind when we are talking about treating the burns patient. As per the age group, our therapy regime should change. If you happen to confront a pediatric burn survivor, you have to involve, play therapy. Actively, you have to involve play therapy. You have to get your things done through puzzles or like coloring or drawing. You have to involve them in a way where they don't realize that they have been made to do exercises. So as a OT, it's very, very important that we get through these barriers. And I think we are very creative as a OT in this part, I would say. One moment. I'm sorry, I think the slides are not getting uploaded. I think maybe I have a network issue. Just bear with me. I think I have a network problem. Just a few minutes. Is it there? Okay, when the slide is uploading, I would discuss about few of my splints, which I want to show you with. See, just in case if the burns patient happened to have a web space contracture over the first web space, you could easily fabricate like a web spreader. So that way you could maintain the web spreading or the opposition which is needed to perform the, the grasping or the functional use of hand. So these are all the few splints which we put it in our patient family education board, that where we orient with our splint when the patient comes to us in his initial appointment, that we want to show that what kind of treatment that he's going to get, or what kind of the splints that he's going to get if he's coming to the occupational therapist care. One moment. Yes, I have done this. It's just uploading. So it's very important for us when we treat the burn patient in the rehabilitative or the restorative phase, we focus on his functional and return to work as per if the age criteria is appropriate, or if it's like pediatric population, we focus on the play or going back to school, those sort of things. So it's very important. We do appropriate strengthening. We focus on, we do a little bit of like their skills evaluation, whether they have acquired enough skills, or if there is any weakness in the muscles group. So we have to strengthen those particular things. We do a bit of simulated activities as a OT. We are always focusing on activities or simulation. So we do all these things when the patient is progressing from the acute phase and he is in the rehabilitative or the restorative phase. Next comes the reintegrative phase. Maybe I'll just go on as the slide uploads. We will see in the restorative phase, as an occupational therapist, we play an important role for the scar management and for the better acceptance by the society or the community where they live. So mainly I'm going to talk about the scar management in the reintegrative phase, which will be the third phase of the burn care rehabilitation. So as a burn care survivor, when he heals, he has been rehabilitated, he started going back. So we start the scar management from day one when the skin is healed. Okay, so there is a tendency that when the burns are taking prolonged time to heal, or there is a delay in getting a skin covering, there is a tendency for the skin to hypertrophy. That is, it can grow away from its surface, like it can raise like a cake. If a cake raises, you're happy, but if your skin rises, you're not happy, because as a burn survivor, it's not so pleasant to have a hypertrophic scar, especially in face or in hand. So our treatment is going to, cater these forms of problem, where we are mainly going to use pressure therapy or a compression therapy, where we kind of put 25 to 32 millimeters of pressure. If you would have undergone like the blood pressure checking in a clinic, your sphygmomanometer cuff gives somewhere around 25 to 32 millimeters of mercuries of pressure. So if we put a pressure garment on the healed skin, that is a burned skin which is completely healed, then that is going to prevent the skin from growing above the surface level. Okay, so the hypertrophic scar can be totally prevented, though the treatment period will be vast. It may take like, 12 to 18 months in terms of, I think, okay, there is a problem. The presentation is not uploading. Okay, so the scar care, when we are doing a scar care, ah, finally, can you see? Yeah, I think it started from the first slide. Okay, I'm now going to go to the current slide quickly. The slides are visible now.
The screen is visible, yeah, but we are still on the title slide.
Yeah. I'm going to quickly, finally,
Yeah,
I could
sure.
upload so yeah, just bear with me. I'm going to start the current view, that the later part of the presentation. So I'm just searching. Give me a moment.
So Jayashree, later on, we will try to maybe upload the entire slide deck on Google Drive or something and share the link on our International Chapter website, because some of them are asking for that to be emailed, which is, this file slide deck is huge in terms of a lot of pictures, so we cannot send it via email. However, we will upload it on our website, and maybe like give us a week or two and then go to our website. You should be able to see the recording as well as a link to the slide deck. Thank you.
Yeah, it's the 446 MB, so I can't upload it. So,
Exactly. A lot of pictures, so it takes a lot more storage to save. So we'll do that. We'll figure out a way and share the link.
yeah, I'm just in my current slide.
Can you tell me the slide number? Maybe as an admin, I can like try to navigate to you.
62 or 63.
Do you see
64.
it progressing? Is the slide progressing for you now?
No.
No. So yeah, because you're the presenter. So if I sync, you are still on slide. Oh, it disappeared now.
Okay.
Guess what, Jayashree, for the sake of time, if you just want to summarize what you want to say through that last slide deck, and then we'll just kind of like upload the slide later on for everyone to view.
No, because a lot of pictures I have, so I would like
I
to show.
got it. So
I can
another way is, yeah, if you want to just kind of send a third part via email to me quickly, maybe I can convert into a PDF and then pull it up here. If you want to shoot me an email real quick, and then I will try to maybe download it from my email and either share it on my end or I'll do something.
No problem though, Karthik. Even if I email you, it's not going. So I think
Even the 1/3 of the presentation is not going either.
yeah, it's not getting uploaded.
Can you save it like a handout? So go to open your presentation on your computer, save it like a PDF handout and send it to me, or no?
My screen is not moving. I think it got hanged.
Oh.
I couldn't do anything.
So again, yeah, I just want to be mindful of everyone's time here. So if you want to summarize, and I know that you want to show the pictures, and I would love to see that. It's very informative, but
never mind. Yeah, we are always ready to. We are adaptable, so it's okay. I have got some samples of the topical liners which we would wear inside our pressure garments. So this would give adequate pressure. So if the surface area is raised, so you can, put a patch of like a gel sheet. Okay, so it's a gel. So you can put it on the top and then you put your pressure garment. So that way it would give like appropriate pressure, especially if you have like a coin size hypertrophic scar. And especially if you have the hypertrophic scar over the curvatures, like for example, the anterior shoulder, or it's in the middle of the palm, where it's very difficult to give a pressure. So during that time, we use elastomer, like as a polymer and a catalyst. We mix these two, and it sets perfectly to a room temperature. and it takes the shape of your body. So if you want to, it's like a Play-Doh. You mix it and you set it on the patient's hand, and then you put the pressure garment. It would give perfect pressure, which is like 25 to 32 millimeters of mercury. So these are the few adjunct therapy modality which we use, especially when we do scar management in terms of patients. And silicone comes as a nice adjunct to use inside our pressure garments, especially when the patient has like the burns over the fingers, you know. So this is like a silicone gel tube. Okay, it has a silicone lining. If the patient has a hypertrophic scar on the finger, you can put this, slide it through on the patient's finger. So you, that way you ensure the continuous pressure, and the silicone would soften the scar eventually. There is a research which talks about there is a difference in the collagen 3 and collagen 1 deposition. So that's why you have this hypertrophic scar happening. So if you apply a pressure over a period of time, that is a pressure garment, so this, that helps in scar maturation eventually. So we talked about splints, we talked about the work, the reconditioning or going back to work, and we talked about the pressure garment little bit on the aesthetic part as a preparation to go back to the community so that they'll be accepted by the community with a better cosmetic appearance. We can't make 100% good, but we can make close to normal. So in such case, we use Vancouver scar assessment for measuring our scar progress in terms of like the pigmentation, the height, the pliability. Is it firm scar or it's like a supple scar? We evaluate it over a period of time, and we usually give 2 sets of pressure garments. So if the patient is wearing a pressure garment for 12 to 20 hours, they have to wash and wear, and mindful that if you are giving it to a child, the child has an active growth spurt. So every 3 months you have to change the pressure garment. And usually in children, the pressure garment spans or the scar management spans for a time period of like 4 to 6 years, whereas in adult, it's like 10 to 12 months, because the growth spurt is almost stopped after 18 years, whereas in children, it's active. So expect that they would be visiting you till 4 to 6 years. If you have a child who have seen you as a at the age of 1, they may be coming for follow-up for 4 to 6 years. So in summary, it's like we as a OT, we mainly help the patient at 3 levels: by splinting, by exercises, activity. It would be more meaningful and purposeful activity as per the client base or the occupation base, and then the scar management. So I, conclude the presentation because I have touched based on all the 3 aspects of the burn care rehabilitation. And here in the hospital where I practice, we are using FIM as a functional outcome measure. Having said that, there are so many outcome measures available, which would be more of self-reported or a burn and health patient-specific questionnaire, which talks about more of how they accept themselves as a cosmetical effect, how they take themselves, or how they have, accepted their recovery as a burn survivor. So these are all the important aspects as from an occupational perspective. And I'm very sorry for the technical part of it. So I conclude my presentation. If there will be a time, we will share in the International Chapter of AIOTA website. Yeah, thank you for all your patience.
I just saw a chat question about any recorded link. Yeah, the webinar is being recorded. So look for the link maybe in a week or 2 on the International IOTA's website. Okay. Thank you, Dr. Jayashree. Dr. Suple, would you like to render the vote of thanks?
Yeah, thanks, Jayashree. Thanks, Karthik. First of all, let me thank all the participants for their support and being with us today. And I'm sure that they must have enjoyed this presentation today, and they will benefit from the information that Jayashree provided today. Secondly, thanks to Jayashree for doing a wonderful job. You spent a lot of time and efforts preparing this presentation, and it was loaded with information. And you talked about body surface area, first aid measures, medical management. You talked about acute stages, pathological changes happening in the body. You talked about the OT part, that was a highlight, a rehab part, ADL conditioning and wound healing and splinting. So you cover whole gamut of like OT's role in burn care and rehabilitation. And I must tell the audience that I visited Jayashree's hospital in Doha, Qatar. She works for the magnificent facility there, one of the best one I have seen so far. I mean, even with the North American standard, like American Canadian standard, those hospitals are outstanding. Yeah. So if you get a chance, do visit her hospital in Doha, and yeah, so you will get a good tour there. So again, thank you, Jayashree, for your really nice presentation. And I must thank AIOTA, Dr. Srivastava, President, and Mrs. Bijlani, Dean Eckhart. She couldn't be here today because of some kind of family function she's having at home. So thanks for them, because they're we work in collaboration with the ACOT and AIOTA. And the last but not the least, I must thank all my board of directors. And let me introduce each one of them on here actually. Dr. Harshvardhan is one of the board of directors from New Zealand. And then we have Sabari Subramaniam, he's board of director from Australia. Dr. Karthik Mani, like I said, he's our all-rounder in our team. He's from USA. And Dr. Ghazala Makta, she's attending the presentation today. She's from United Kingdom. Dr. Shruti Nadkarni, one of the board of directors from Dubai, and Jayashree, of course, from Doha, Qatar. And if you don't know me, I am Vijay Suple. I'm the convener of the International Chapter of AIOTA, and I am based in Canada. So again, thank you, everybody. Thanks, Karthik, for arranging all this technicality, and you are pretty pro at it. And I'm sure this all the students will go home with some kind of loaded information, so kind of their knowledge base is increased from this presentation today. And we will upload this presentation on our webpage, so www International Chapter AIOTA, and it should be there within a week's time. And you can make notes actually. I was kind of it was good for me also, like it refreshed my knowledge. Yeah, because I haven't worked in brain and like a burn and rehab, so it was really a kind of nice presentation. So I thank Jayashree again, and thanks everybody. So have a good evening, and back to Karthik, if you want to say anything, Karthik. So
Yeah, so make sure that you leave your name and email if you are looking for a e-certificate. And again, we hope that you benefit out of this presentation. There will be a survey as a follow-up to this webinar, just to gather your feedback and input. So, please spare a few minutes to complete that as well. You will receive that within a day or two as well. Thank you so much, Jayashree, for the wonderful, informative presentation. Thank you, everyone. And I'm going to end the meeting in a minute. So I'm going to leave a minute so anyone wants to put their email in the chat, and then I will end the meeting. Take care, everyone.
thank you. Bye-bye.
So there is a question in the chat. Where's the feedback link? It will be emailed to you. We'll email you the survey link. All right, it looks like a lot of people have submitted their emails, so I'm going to end the meeting. Okay, still coming, so let me wait for 30 more seconds. If you already put your email in the beginning, you don't have to redo it. Just kind of telling those who joined a little later couldn't get my information in the beginning. So if you already provided your email, you're good. Still the emails are coming, so I'm kind of holding on. All right, so I'm going to end the meeting now. Thank you. Bye, everyone.